topic for today is comparative study of IOL decentration and tilt among sutured SFIL and CMT flex IOLs. The ideal placement is in the capsular bag, but it is not possible in complicated cataract cases, in ocular trauma or subluxation of lens. So the transfemoral fixation is one of the common choice, but again sutured SFIL have their own complication, tilt and decentration being the common one. So foldable scleral tech IOLs are relatively new and are avoid of suture related complication by virtue of their design. The aim is to compare the IOL decentration and tilt among 2-point fixation and CMT flex IOLs. It's a case control study conducted in aphakia secondary to complicated cataract surgery, secondary to trauma and any congenital subluxation or dislocation of lens. It's done in a tertiary care hospital. Case with uveitis, high refractive error, glaucoma, macular diseases, pale disc were excluded. Following parameters were assessed like visual acuity, autorefraction, slit lamp, fundus and OCT. They were randomized into two groups with 43 eyes in each eye. Group 1 is CMT flex IOL, group 2 is 2-point fixation SFIL. The post-operative IOL decentration and tilt were measured using anti-gown machine. All the measurements were done at 1, 2, 3 and 6 months post-operatively. The IOL decentration and tilt was calculated using ImageJ software. As you can see, the A is the visual axis, the R is the spur-to-spur distance. This is obtained in the anti-gown machine, and we can obtain the anterior and the posterior border of the IOL. The parallel line is passed where these two borders intersect. That is the plane of IOL. B is the center of the IOL. The difference between A and B, that is the IOL center and the visual axis, gives the IOL decentration. Now coming to the IOL tilt, angle R is the angle between the visual axis and the spur-to-spur distance, and angle C is the angle between visual axis and the IOL plane. The difference between these two gives the angle of tilt. This is a post-op image. In the results, 22 were male and 21 were females in each group. The mean age was 41 in group 1 and 48 in group 2. The pre-op BCVA was logMAR 1.43 and logMAR 1.77 in group 1 and 2 respectively. There were no significant difference in the post-operative BCVA in both the groups. Now coming to the IOL decentration, at 6 months the horizontal IOL decentration in group 1 was 187, whereas in group 2 was 296. Whereas vertical IOL decentration in group 1 was 143 and in group 2 was 294. Both of these were clinically significant. Coming to the horizontal IOL tilt in group 1 was 1.2 degree, whereas in group 2 was 2.7 degree. Whereas the vertical IOL tilt in group 1 was 1.23 and in group 2 was 2.6. All of these were clinically significant. It can be seen that CMT flex IOL had lesser tilt compared to the sutured SFIL. There were few postoperative complications like cystoid macular edema which resolved following posterior subtenon triamcinolone injection. Now coming to the discussion, 2-point fixation is more commonly used, but there is increased incidence of tilt and decentration which induce higher order aberrations. Around 2 to 3 degree tilt and 0.2 to 0.3 mm decentration commonly goes unnoticed, but larger extent of tilt and decentration has negative impact on the optical performance like visual acuity, dysphotopsia, wavefront aberration, and subsequently the patient's satisfaction. Study conducted by Zhang et al. And Sul also showed that the decentration and tilt were higher in the sutured group compared to the non-sutured group, but this was for the, they have conducted it for the Yamane. Now, the study conducted by Nivian also showed that the long-term effectivity of CMT flex IOL.
The slide where AI was?
You can go to the slide first.
Last slide.
A study conducted by Nivian showed that the CMT flex IOL is an effective method to correct aphakia with reliable and safe long-term result. There were no decentration or any dislocation, haptic exposure or retinal detachment noted for a follow-up period of 2 years. No eyes required any resurgery. Conclusion, it is CMT flex is a reliable, safe option in planning secondary IOL. This technique provides an anatomically well-centered and stable IOL with significantly better tilt and decentration profile compared to sutured SFIL. Now coming to the limitation, the prolonged follow-up periods were needed for assessment of long-term outcomes. Measurement of higher order aberrations could have added more value to the study, and the larger sample size and including other group of SFIs like Yamane or Kenabrava could have added more value to the study. These are my references. Thank you.
So I was just coming to that. Wonderful presentation. You could have shown a video also of the surgery anyway. But the comparison between others, sutureless SFIs is very important.
Yes, sir. And one more thing about the CMT flex is it is less manipulation of the tissues and it is sutureless, so the suture related complications are less. And it is a surgery which can, the learning curve is very short. That is what, compared to the other study, the CMT flex IOL have a better profile.
I know where you are doing your practice, but just for the scope of
Yes, sir.
do you routinely do a vitreous base?
Yeah, not vitreous bed, but we do a complete core vitrectomy, not like base shaving also we do, but the core vitrectomy is required, not just the anterior vitrectomy.
CMT flex is comparatively new procedure. So any complication, at least in the learning curve, like what thing needs to be kept in mind?
The thing is, while we inject, the forceps should be held at the T junction. If it is not held at the T junction, there is a chance that the T can cut. And one more thing is that when we do a 23 gauge entry, the thing is that it should be a 23 gauge. If it is larger than that, I have seen one case where on table the haptic was stuck, but post-operatively, because of the larger entry side, the IOL had got dislodged. I think that is also one of the things which should be kept in when the smaller 23 gauge entry and the to be held at the T junction.
You must do a comparative analysis with Carlevale lens. You know, Carlevale.
Okay.
You must have heard of Carlevale lens.
No, sir.
Using the specialized forceps for this.
Yes, sir. Specialized.
How much is the lens costing?
MRP is 5,000.
Right, correct. This is done by Appaswamy.
Appasamy Associates. It was prepared by Dr. Nivian, by Indian.
And what is the difference in biometry, power calculation in such cases?
No, biometry it's the same. What we use for the routine CMT flex, that only we use.
Correct.
Thank you.
Thank you.
Thank you.